This is where the ground breaks. What's never been done is what we do. It takes a city to change the world.
Hello, everyone. My name is Julie Kenville, and I'm CEO at UHN Foundation. Thank you so much for joining us today. And I'm happy to welcome you to this United Behind the Scenes conversation series. This is when UHN Foundation, 4 times a year, we host incredible conversations with some of our experts. We are trying to bring our advancements, our medical discoveries, the latest cutting-edge medical breakthroughs into your home. We are bringing our experts to your family and to your household. Now, we're going to be taking your questions today, so please make sure to submit your questions on Slido. You'll see that at the bottom of your screen. Now, it's a wonderful time today. We are talking about social medicine. And before we do that, we want to talk about UHN. We want to make sure that you know what is UHN. Now, it is the #1 hospital in the country. There are 44,000 people who work at UHN and who study at UHN. It is the Toronto General Hospital, the Toronto Western Hospital, Princess Margaret. We have Toronto Rehab, 6 sites. We also have West Park Rehab that joined UHN this past year. And we have the Michener Institute, which you will hear about today. It is the only academic institution in the entire country that is funded by healthcare. And there are many professions that are taught right here. And in fact, the only place in the country where you can learn those professions in English, which is incredible. I did mention that it's the #1 hospital in Canada, but it's also the #3 most important hospital in the world. That is incredible. But what is most meaningful to me and to many of my colleagues is that UHN is the #1 publicly funded hospital in the world. And that's meaningful because here in Canada and at UHN, we care for our most vulnerable patients just as well as we do for our wealthiest patients. And that's extremely important to the topic that we're going to discuss today about social medicine, about homelessness. We have a lot of challenges in our healthcare system. We read about them each and every day. But I like to focus on solutions. I like to focus on what we are most proud of in this country. And we punch way above our weight internationally. There are many, many different discoveries that have occurred right here at UHN, that have occurred right here in Toronto. But all of that is only possible thanks to the generosity of our community and thanks to the passion and determination of our incredible medical experts. Now, we're talking about homelessness and we're talking about social medicine. So let's think through some of the statistics. Homelessness in Canada ranges between 150,000 to 300,000. Toronto has the highest number of homelessness in the country. 33% of homeless are actually from Indigenous communities. 2/3 are racialized. The annual cost of homelessness in this country is well over $10 billion. But what is the impact of homelessness on health, on individual health? And what is the impact on our hospitals, on the care that we receive in hospital, and on the costs of hospitals? We will explore all of that with you today. Now, the question I am going to be asking today is how can you and I have an impact on these solutions? How can we help the homelessness crisis in our country, and how can we better support our hospitals in addressing this national crisis? Today, I am absolutely thrilled to be joined by 2 of our experts in social medicine. Dr. Andrew Bozzari is a primary care physician and researcher. He is founding executive director of Population Health in the Gattuso Center for Social Medicine. He completed his medical training at the University of Toronto and then health policy training at Princeton and Harvard University. His work is at the intersection of health policy and social justice, equitable healthcare delivery, and how it aims to improve health outcomes for marginalized populations. Many of you know Dr. Bozzari was listed in Toronto Life this past year as one of 50 most influential Torontonians for 2024. He was also, last week, recognized as a 2025 Adrienne Clarkson Laureate for public service from Massey College. And this was to celebrate the transformative leadership in advancing health equity and social justice. Thank you, Dr. Bozzari. Dr. Kate Heyman is an emergency physician. She is the site lead for Toronto General Hospital's emergency department. She's deputy medical director for emergency medicine at UHN. She completed her medical training at Western University and her master's in public health at Johns Hopkins University. Her academic and clinical focus is on improving emergency care for people experiencing marginalization, particularly those experiencing homelessness and substance abuse. So Dr. Heyman and Dr. Bozzari, thank you so much for joining us. And thank you for joining us today. Please do submit. I do see some questions starting to roll in, so please submit your questions that you would like for us to ask our doctors today. And you can also vote on the questions that you most wish for us to ask today. Now, let's start with Dr. Heyman. We're experiencing an incredibly cold winter right now, and so homelessness is top of mind for all of us as we walk through the streets and complain about the bad weather. What is the impact on our emergency rooms?
Yeah, thanks, Julie. First, I hope everyone watching is staying safe and warm. It has been tremendously cold this year. Our emergency departments, so we have two emergency departments, Toronto Western and Toronto General. And in the winter months at each site, we see approximately 20 people per day who are experiencing homelessness. So the impact is pretty significant. It's about 10% of our visits are people who stay in shelters or people who stay on the street. And there's kind of two big categories of reasons why we see people. We see people for medical reasons and then to meet their non-medical needs. So medical things could be like skin infections, exposure to the cold, so hypothermia, frostbite. We see people who can't meet their chronic medical needs. So for example, if you have diabetes and your insulin is frozen, there's no way to administer it. And you can't look after your medical condition the same way as someone who is housed. We also see people that come to the emergency room because they don't have a connection to a family doctor. And we know that people who are homeless in Toronto are actually much less likely to have a family doctor than folks who are housed. We also see many people who are coming because of unsheltered homelessness and they just need a place to stay. Since 2009 in this city, we've seen every year, year over year, a rise in the number of people who are unsheltered. So folks who stay on subway grates, who stay in bus stops, who sleep outside or sleep in a tent. And we're seeing those folks in our ER who come in for shelter, they come in for warmth, and they come in sometimes for a friendly conversation and to get a little bit of support that they can't receive somewhere else.
Can you give us a sense of numbers? How many people would be using our emergency room right now?
Yeah, so up to about 200 a day at each site. And so about 20 of those are unsheltered. So, you know, we may see 10%. In the coldest days, sometimes we see more. At peak last winter, we saw up to 40 per day at our Toronto Western site who are unsheltered. So really unprecedented numbers. And I've been here a decade, and it looks so fundamentally different, the crisis now, than it did 10 years ago.
How is it different from 10 years ago?
I mean, the volume, and we see the unmet need is so critical. I think many people think about folks who are unsheltered and picture people that are chronically homeless who maybe choose to stay outside. We know that is simply not the case in Toronto. So when we look at the unmet need, we know that more than 100 people try to get a shelter bed every night and can't find one. And so that often drives them to the emergency room or to connect with some of our other resources that we'll talk about a little bit later. So that unmet need is so different and continues to rise in the city.
Dr. Bozzari, what are some of the drivers to homelessness?
Yeah, I'm happy, to unpack that. I just wanted to start by saying, really honored to be able to have this conversation together, especially with Dr. Heyman, who's a very close colleague, friend, and leader in this work over the last 5 to 6 years. I think Kate did a tremendous job unpacking a lot around the epidemiology of the number of people who are coming in. When we look at the drivers of homelessness, I think Kate alluded to this a little bit, that it's getting worse because, one, we have to understand this is a housing crisis. For people who are not unhoused, who are watching and have had, relative comfort or ability to want to give back in certain ways, I think people are starting to notice just how challenging it is to live in the city. If they have loved ones or people who are struggling to pay rent in the private market, these are things where, paycheck to paycheck, it's getting much harder to stay housed. And these are now impossible decisions now for far too many families in the city, in the country, that are choosing between refilling their medication, paying their rent, or paying for groceries. So I think of people who are watching and seeing this are seeing the real cost of living crisis. And that's a major driver of homelessness. When you look at the fact that rents have gone up a catastrophic amount over the last 10 years, this has been pushing and flooding people into homelessness. So it's really an affordability crisis. And I think Kate raised a really important point around people choosing to not seek housing, or people don't want help. That's not the reality. When you look at the data, these are policy choices. So if you look at it 50 years ago, we sort of started these discussions around social medicine in Canada. About 1 in 5 or 20% of all housing options had social support, or there was social housing, there was public subsidies, it was affordable for people. We now have less than 3% of the housing stock. And so it's so bad that Scotiabank put out a report. I think, Julie, you mentioned some of the numbers of the cost of the economy. Scotiabank has put out a report saying we need to double the amount of social housing in this country to stop the driver and flood of homelessness that is good for people's individual health, but also the economy. And I think the other important piece in this is if we doubled the amount of social housing tomorrow or in the coming weeks, we would only be at our peer country OECD average. That's how far behind we are in Canada. So I think it's really illuminating that these are real policy choices. And really, I think anyone watching is starting to see just how much the threat of homelessness is in place around people not able to afford their rent, higher rates of eviction coming into place. And then, of course, where there's this relationship between mental health and the real precarity of housing that I will argue is really bi-directional. It goes back and forth in both ways.
Yeah, we keep hearing that the homelessness crisis is caused by fentanyl. Is that the case?
It's not. It's not. And I think fentanyl, which we can talk about, is a terrible synthetic drug in the sense of what it has, how many lives have been lost because of this toxic drug and the toxic drug overdose crisis. And, I know that Kate has done tremendous work in this area, community leadership, to try to stem the real tide of avoidable deaths. It's hard not to get emotional talking about fentanyl for those of us working in front outpatient and emergency department spaces, seeing the numbers that we've lost of young people, of people later in life. But when you look at the realities around mental health and homelessness, when you have people exposed to chronic homelessness, they're far more likely to use substances, and they're far more likely to have worse physical health conditions. And so it's compounding. So when saying it's bidirectional, if you have, everyone has predispositions to different mental health conditions, different physical health conditions. And what homelessness does is it doesn't cause these issues to take place, but it worsens them, it exacerbates them, and they end up in the emergency department with conditions that could have been treated like diabetes upstream. But because of the fact that they're unhoused, we're now looking at realities of people in one of the richest countries of the world needing amputations for really routine things like diabetes. So I would be vehement that it's not driven by fentanyl, but it's definitely a very important issue, and substance use is something that we need a more concerted response.
Now, thanks to a generous donation from the Gattuso Foundation, you created the Gattuso Center for Social Medicine, which we will talk about some of the pilot projects that you've launched, and you've been able to demonstrate some extremely positive impact. I'd like to start by the peer workers. Can you tell us about what is a peer worker and what difference did it make in the emergency room?
Yeah, so I mean, the peer program is, I think, one of the most fundamentally transformative programs that we've had in the emergency room in the last 5 years. Our peer support workers are employed in collaboration with the neighborhood group, our community partner, and they are people who have lived experience of substance use, mental health challenges, or homelessness. And they work in our emergency room 7 a.m. until 11 p.m., 7 days a week now. And they support people with similar challenges in the ED. So people that have been using drugs, people that are homeless, or people who have mental health challenges. And the support really varies. A key part of the peer approach is meeting people where they're at and offering the support that the person needs in that moment, as well as sharing their lived experience. So to give you some examples, a lot of what the peers do is say, hey, I see you, I see where you're at, and actually, I was here too. And I know what it feels like to be intoxicated or to be in withdrawal and to be on a hospital stretcher. And one thing the peers can offer that I can't offer is they say, you know, I was in your shoes and now I have this job and I get to talk to people like you and offer you a bit of hope and tell you what worked for me and tell you what else is out there. And the potential to create that human connection in our emergency departments, it's fundamentally changed things in so many ways. The peers are able to provide that support, and they also do things like help call for shelter, help call for detox beds, help patients navigate resources. That offloads our emergency teams. So they're not making those phone calls, and it gives them capacity to look after someone coming in with a heart attack or, you know, do CPR and some of these other resuscitative things. They're not mutually exclusive categories, but having the peers on board helps to reduce the stress, and particularly, you know, that feeling in the ED like, what do I have to offer you? Sometimes having food and a warm blanket and a friendly conversation and a naloxone kit is a tremendously, tremendously impactful encounter. And so we're really grateful that we have the peers. This fiscal year, they've supported more than 2,000 visits to give you a sense of the scale. So this is a huge number of people who are benefiting from their support.
What I love most about this example is that we created a brand new profession, now fully integrated into the emergency room. And the next step now is, how do we bring peer workers to the rest of the country and to every other hospital in Canada? Maybe Dr. Bazari, do you want to tell us what are the plans for the future for peer workers?
Yeah, and I think the story from Kate is so positive. I mean, remember when we started this with the neighborhood group and Lori Steer and Bill Sinclair and folks who did some tremendous work, just really at the beginning of COVID. The idea that you'd have people with lived experience working alongside physicians and nurses and social workers seemed radical. And I think now it continues, as Julie mentioned, to be one of the most sought after programs to keep in place and actually to scale. And so I think one of the things that we're really looking at in partnership with community is how to work with Michener and ensure that we can start to see different training and scaling programs for people who want to do the sort of community health worker aspect or social medicine navigator roles that we started to see in place through some very generous philanthropy that has allowed us to start to embark on this pathway. I mean, I think the other part that we have to talk about is that the peer worker experience in the emergency department has really helped shape so much of our idea of how we scale that across the hospital, both for various parts of the hospital ward to different programs. But what we saw through the pandemic of people accompanying folks and the trust that they built with people was in many ways far greater than some of the trust that we have as clinicians. And I think it's really important that we embrace that as a team, we build these new healthcare teams. And I think UHN has been really well positioned, given these relationships and partnerships, and with institutions like Michener, to start to be able to help scale programs like this that really center human connection, as Kate mentioned.
So we're a hospital, we're not a shelter, we're not a community group. Why do hospitals need to get involved in social medicine? Dr. Bazari, maybe you want to kickstart on that.
Well, I think it fundamentally matters to your point around the evidence and the research innovation. I think you laid out the importance of us being recognized, and this is, extends to the entire organization, of being the #1 publicly funded hospital in the world. And I think that the goal and the mission and the mandate then would be to how to have the #1 social medicine program in the world. And the realities are that we know from decades of evidence, hundreds of years of research, of publishing in medical journals, the importance of the drivers of health that happen outside clinic walls, outside hospital walls. So some things we've talked about: homelessness, the air people breathe, loneliness, the jobs people have, the kind of connection that they have, the ability to have walkable spaces, to be able to have food security. These have far bigger impacts on people's health than some of the things that Kate and I can do in a clinical setting. So to me, the challenge is, as we're the #1 publicly funded hospital, recognized as such, if we're the University Health Network and not the University Healthcare Network, really the importance of being able to bring interventions that promote health, that drive health in a sustainable way, to me is really core to our mandate and mission as a global institution.
Dr. Heyman, another great innovation that came from the Gattuso Center for Social Medicine was the Stabilization Center, which has been transformative for UHN. Can you tell us about it?
Yeah, so the Stabilization and Connection Center is a non-medical space, so it's staffed, again, with community partners and has harm reduction workers and peer workers, and helps people when they recover from intoxication by drugs, typically opioids and alcohol. And what happens is, so for example, a paramedic picks up someone who is intoxicated by alcohol. They have stable vital signs, but they can't walk, they're unsteady, and they're at risk of harm in the community because they could get injured, someone could injure them. The paramedic can bring them to the Stabilization and Connection Center, and that person can stay there and rest, get supports if they need a place to stay, if they're experiencing homelessness, the peers can help them find that, or the harm reduction team can help them find that, and the folks in that space can help them get the care that they need in the moment that they need it. The impact on our ED, on our emergency departments, typically there's about 7 visits per day to this space, and people stay there for about 8 hours at a time. So, you can do the math and start to think about the avoidable hours of emergency department bed use. People are getting the care that they need in a different space, and that enables our emergency teams to have more patients in beds and provide care for them in the most appropriate spaces in our EDs. The impact on EMS is also tremendous. When the paramedics bring people to the Stabilization and Connection Center, they offload them within minutes, which means the crew can get out onto the road and care for the next person who's experiencing an overdose or a heart attack or a child in distress. We know that, unfortunately, in our emergency rooms, the paramedics might not get back on the road that quickly, but they get out really quickly when they go to the Stabilization Center. So this is tremendous, both in the care that it's providing individuals, but also in the impact that it has on the health system, and it would not have been possible without philanthropy.
The beauty of this solution, and Dr. Bazari, I'd love to hear from you on that, is that it can easily be scaled across the country. How difficult was it to implement this change?
Well, again, I think, and of course, working so closely with Kate and emergency department leadership to see this happen, I think the point again of why we're here, being able to do this with philanthropy was massive. But of course, from the top levels of the organization to Dr. Kevin Smith, believing and wanting to do something different, and really the realities in December of 2022 that Kate laid out, that we had our emergency departments on fire. There were the paramedic access was in real crisis to be able to get out. And there was willingness from UHN to innovate with the support to say we're going to take a different approach, a different solution to an issue that's been chronic, but it was getting worse, with community partners. That's the other piece, that we did not do this alone. That as Kate mentioned, the neighborhood group, Parkdale Queen West Community Health Center, Inner City Health Associates, Toronto Paramedics, the City of Toronto, that really happened so quickly because we'd done so much of this work for 5 years prior, through the pandemic, through various parts and junctures of real hospital and community challenges, that we could just be able to implement something really quickly. And I think the other piece around the data, that previous time that we heard from the chief of the paramedic service was about 3 to 4 hours that Kate alluded to in terms of how long it was taking. I'm now so moved to report, and this is really a testament to the frontline work at the Stabilization Connection Center. There have been close to 5,000 patient admissions, and the median drop-off time, the average, is less than 6 minutes. So the hours back to the system, and to Kate's point, and the point that we really made in the beginning, is this is not just about the system savings. This is going to be about preferential care for people who do not have good care experiences, which again really aligns with the UHN mandate about transforming patient experience and community experience in this work.
Dr. Buzari, you were the first physician in Canada to prescribe housing. Can you tell us a little bit about how that came about and what's been the impact so far?
Yeah, I mean, it's, again, kudos to so many partners and work. And I think, one thing that we're learning, the idea about prescribing housing seems so simple in some ways that Kate and I could sit and write a script. But the realities are that this took years of work and years of groundwork with the City of Toronto and community partners to get us to this point here in just November of 2024. And really, with Fred Victor now running the nonprofit operations of the site with their vast experience, I'd love to say, that it's as easy as writing a script for people, but it goes back, Julie, I think, to this theme around trust. And it's years of work to build the trust with both patients and communities, that when you can write the script for housing, that people trust you to be able to take it up, and that you have trusted partners that can deliver the highest quality health and social care support that's in place. And so I think that's something to me that has been so moving. And I think, I was just the other day being able to speak a little bit around our evaluation plan at the university, and a psychiatrist had actually stopped to be able to say, and I did not know them, I've not worked with them before, but that 2 of their patients serendipitously had moved into Dunn House. And one of them had not spoken to their kids in 20 years, but had finally been able to reconnect with them in moving in the last month. So it was hard not to stop and be emotional, and you continue to hear more and more of these stories. And it's 51 housing units which have become homes for people. But as Kate and I have talked about, and I know you and I have talked about, the real promise of this is how we scale this, and that this becomes prescribed policy for hundreds and thousands of people, and that we don't stop here.
Now, this is an important policy debate at this moment, and we've heard many calling for the removal of all the encampments. And I'd like to hear from both of you. What are the solutions, and what should we be doing? What should our audience be thinking?
I think Andrew has really fundamentally underlined, what we need is housing and what we need is affordability. The driver of this crisis is fundamentally poverty and a lack of housing. So I think in a big systems way, that's the critical piece. When I think about what's working from a healthcare point of view, I think Andrew's really underpinned some of this, talking about trust and talking about choice. So the reason people are moving into Dunn House now and are moving out of other spaces is because they trust the person who asked them to sign their lease. They trust the community health worker who saw them. I don't know how many encounters it took for the community health workers to build many of those relationships, but some of those relationships start with the peers in the emergency room, or they start at the Stabilization and Connection Center, and some of them started at our winter support space last year. So they were these routine encounters that became so critical, and on each encounter, the trust was built, and the patient had a choice to continue to engage with the services. And slowly, over time, they've been able to move into places like Dunn House. When we think about the approach, for example, to encampments, I think recognizing the real strength that we've seen in the social medicine program that enables people to support and protect their autonomy, but to engage in a trust-based model where they really believe that their providers want the best for their health, they want the best for their well-being, and that brings them to a space where they can start to imagine something better. I think that's really what the social medicine programs have built, and those are the models that we need to move forward with. Models where we see enforcement and we see people being forcibly pushed out of spaces makes it harder for them to receive health care, and it breaks trust with the system. And every shift when I go to work, I'm trying to slowly rebuild a bit of that trust, in large part with our community partners. So I hope we can continue to focus on solutions that center people's humanity and their well-being as we move forward.
Dr. Bozzari, what is the cost right now of this crisis on our hospitals versus the shelters and social housing?
Yeah, I mean, the economic aspect to this, I mean, Kate has done such a great job talking about the human dignity, and I think that's what really centers so much of work at social medicine. But when you look at the cost, the status quo right now around our failure to deliver housing for all, it is incredibly expensive on a human dignity front and also on the matter of health economics. So a patient who would be admitted to our hospital, UHN, or really any downtown hospital, would be over $30,000 a month. When we look at the costs for people in the prison system, which I fully agree with Kate that punishment and policing is not going to get us out of the encampment policy, wicked policy problem. It's about $13,000 a month in the prison system. And a dear friend of mine and mentor, Lana Fredo, calls it the de facto mental health system because people cannot access mental health supports. And I know of a patient story for myself working out in Regent Park who told me that they decided to throw a stone through a window because they could not access mental health supports, and they would actually get supports in prison as opposed to the cruelties of trying to move through the shelter system and access mental health care. And then when you look at the shelter system, it's around $5,000 to $6,000 a month. And when we look at all of the evaluations around supportive housing, it's less than $4,000 a month. So it's a real, it's when people ask, can we afford housing for all, or can we afford more done houses? I think the reality is I don't believe we can afford the status quo.
Now, I want to take some time to get to your questions. I'm seeing quite a few, so please continue to submit your questions on Slido. But before we get to that, two questions for you. And the first one is, would you have been able to do these great pilot projects if it were not for philanthropy? Why is the government not paying for all these great initiatives?
I mean, it's a great question, and I think the answer is no. Philanthropy has enabled us to be responsive and creative and to build evidence. So when we talk about the peer program, there were small peer programs happening in the States, for example, around substance use, a small mental health program happening at one of the other hospitals in Toronto, but no other peer program with the scope and the same community partnership model that we're using with TNG. And to go and ask the government to fund something that doesn't necessarily have a really strong, robust evidence base, that's a challenging ask. I mean, Andrew does that asking. I don't do as much of it. But the philanthropy enabled us to build the evidence base and to try it and show that it works. And now we have a lot of that evidence. Some of it is published in the medical literature. We have experiential evidence in the press. Some of our peers have been able to tell their stories. And that enables us to start to show funders at the provincial level, hey, look at what we were able to do with philanthropy, and now can we look at a different funding model? But that responsiveness and that flexibility, that was absolutely possible because of donor support. So we're so grateful. And the peer program, I think, is a great example of how we've managed to support that transition.
Dr. Bozzari, you're launching an eviction fund and another program for food security. Can you tell us a little bit about those that are funded by philanthropy?
Yeah, I mean, I think, one, I just have to reiterate Kate's point. I mean, I think that the philanthropy piece has been the biggest game change for us to be able to do this work. And I think when we look at the ability of the risks we've been able to take, and to your point around not just resorting to Band-Aid solutions, but be able to put out things that can build an evidence base and are already being scaled. I mean, Kate used the example of the Stabilization and Connection Center. That's now being looked at to be scaled in various parts of the country, let alone, the province. So being able to have that has been instrumental. I really, will wait on acknowledging and shouting out some of the amazing philanthropy for the gifts that are coming underway for food security and for the prevention eviction fund and for the hubs. But I think really we're really excited to be able to articulate this further, where we're seeing huge lines at food banks that we've not, to Kate's point, we've not seen before, that people are showing up with food insecurity in emergency departments. There's been great literature, especially at the end of the month when there's exhaustions of food budgets, which we're really excited to be able to announce soon about this work of being able to prescribe food as medicine for people to help keep them out of the emergency department and improve their health outcomes. That we've seen already measures of things like A1C or blood sugar levels that can be really helped and addressed. And then the other piece is around the eviction prevention aspect. There are so many people now so there are two factors. There are many people that are at risk of becoming homeless, and that I think is the big piece of some of the different drivers. So the people who are currently unhoused, and we're not doing enough to be able to bring new housing solutions, but there's such daunting risk of people who are precariously housed and are 1 or 2 months rent away from becoming unhoused. And it's much harder to have people become rehoused once they become evicted, and there's a terrible crisis that has real physical and mental health impacts that we're looking to really avoid and prevent through that fund. And then I think around the hubs, which again we're really excited to be able to announce soon, is how do we build on these learnings from the Winter Support Center that Kate mentioned, that allowed us to build relationships. Now 2 years ago, 8 patients and clients who came through the Winter Support Hub are now currently housed at Dunn House. So it's these various efforts that over many months and years build trust to allow the next initiative to actually have even greater success. And that's what we've been really trying to do, is build on these pieces that these initiatives now will be coming out shortly, but also I think the opportunities that are rising soon.
So we have a wonderful question here from my 7th grader who is writing a speech on this topic. How can emergency rooms better connect patients struggling with substance use to long-term recovery resources? Dr. Heyman.
Yeah, so I think what is so critical is that at every encounter, we meet people where they're at and we offer them options, a range of options. And we know that the mortality rate for people that come in with a non-fatal overdose in the emergency department is tremendously high, and it's actually higher than for most of the other conditions that we see. So you're more likely to die in the next year if I see you after a non-fatal overdose than, for example, a heart attack or pneumonia or many kinds of infections. So the intervention in that moment is critical, and having people like the peers to support that is critical. In terms of where we can connect people to, we fortunately have access to a rapid access addiction medicine clinic here at UHN. So patients can be seen either by substance use specialists in the emergency department at our Toronto Western site, or can visit the rapid access addiction medicine clinic for same day or next day supports. And that referral is also possible from the Stabilization and Connection Center. And once people are there, they are able to access, and sometimes also directly from the emergency department, medications to support them with their substance use. And we know that medication-based therapy is far, far more effective than abstinence-based therapy. So if people want to get started on medications to help change the way that they use drugs, that's absolutely possible. And for folks who maybe aren't in that place, they can get connected with peer supports, get access to things like naloxone, and can talk about overdose prevention planning with our peers to hopefully ensure that when they come back in a different moment, at a different time, and they want to talk about their substance use and what long-term recovery looks like for them, then we're available in that moment.
Another great question linked to that: what advice would you give to our youth about substance abuse?
Yeah, so I think as an emergency doctor, some of the cases that haunt me the most is when I see young people who are experimenting with substances that they did not expect to contain fentanyl that did. So, for example, a teenager at a party who uses cocaine, the cocaine is laced with fentanyl, and they have a fatal overdose. Those are things we never forget about. And I'm not trying to scare people. The message here is not like abstinence only, don't do drugs, but the message is it's really scary what's out there. And as a parent, I think it's really scary what's out there. And so for people who are talking to their kids, ensuring that people don't experiment with substances alone ever, that someone has naloxone, that people know how to recognize an overdose and how to call 911, I think is so essential. And to know that you're not going to get in trouble. So when you call 911 because someone is in trouble, you're not going to go to jail. That's so critical to prevent your friend from getting into trouble and potentially even dying. So I think that's some of the safety information that I would give kids or youth.
Dr. Buzari, we have a question here for you. How do you collect data on the unhoused?
Yeah, well, I think that it goes back, on the theme of the discussion today around trust, right? I think that there's realities that to be able to collect data requires trust, and that's something we've been able to do now over a number of years. I think the challenges have been that we've not done a great job of collecting data historically for people in unhoused. There's only recently been new codes for emergency departments to better track and analyze who is unhoused, who is at risk of being unhoused. These are efforts that we're trying to be at the forefront of at UHN with the emergency department, which I think is important to outline, that has really functioned as the last thread of the social safety net, right? In terms of why this really important marriage between social medicine and the emergency department is that there needs to be that sort of connection to better understand the dynamics of why people are coming in, but then also to co-design those solutions. So the data is really paramount. What we've been able to do is collect data through community health workers, through folks who are there who have social medicine navigators, who are building trust to better understand what's happening. And I'd also argue a lot of it is the advocacy for better data collection. That's something that the Gattuso Center takes really seriously. We work with the City of Toronto, various partners, trying to see more street needs assessments come into place, better understand the housing supply that's required, the kind of housing and health supports that are needed. Because I think the data is really clear for people who are unhoused. You can look at it in almost every jurisdiction. People who are unhoused chronically live half as long as the general public. So that means for people watching that you or a loved one would lose 30 to 40 birthdays. If there was a drug to reverse that, we would hope that every funder, every investor, every philanthropist was doing so. We know how to prevent that. The solution, the treatment is housing. So I think the data is really important. We have some good data already out there. We've collected more data, as Kate has mentioned, are publishing more data on the importance of these interventions. But it's something that, again, we have some really powerful stories and compelling data to act on.
So Dr. Buzari, you have another question linked to that about how do we know that Dunn House will have an impact on the number of ER visits by our homeless population. But linked to that, I'll add another question for you, is can you help our audience understand how you selected the individuals, the 51 individuals, to move into Dunn House?
Sure. So I'm going to take the question in reverse. So I'll start with the second question. So part of what has made the Dunn House initiative unique is that for the first time we linked data between the City of Toronto and University Health Network, between hospitals and the major municipal government around that has really been tasked with housing, whether it's through shelter or other supports. So when we looked at the data, it became clear that around 50 to 60 patients made up over 3,500 emergency department visits. So people were coming into the emergency department because they have nowhere else to go. Kate outlined some of this in terms of whether it's for shelter or they had really worsening health conditions. So we saw that there is a cohort of patients that have a disproportionate use of health services, that have disproportionately worse health outcomes. And that was really the focus of this for UHN patients who've been at the Toronto Western or Toronto General Emergency Department or had been admitted to hospital. And so we were able, for the first time, to take the highest degree of people who had the most medical complexity, as determined by a number of various factors, but mainly emergency department visits and hospital readmissions, or total hospital bed days, that they've been languishing in hospital beds, as well as how long people have been waiting for housing. So there's no perfect algorithm in a sea of inequity where people are waiting over 10 years to access social housing in Toronto. But it was the first time that we were able to integrate this data and inform a criteria that had not been established before. On the first question, how do we know it's going to be successful? Again, I think the power of philanthropy to allow the partnership with Ariadne Labs at Harvard University and many stellar researchers in the homelessness space here in Canada are part of this evaluation and driving this that is extensive, not only looking at the quantitative aspects, is this going to drop ED visits, is this going to see cost avoidance and cost savings, but the qualitative aspects of the stories that are there, the power of these narratives to combine and integrate this to tell the story of what's happening at Dunhouse, because it's a very complex intervention. It's for people who have been denied basic human rights like housing for years. No one believes it's going to change overnight, but what we do hope and what we see from the evidence is that if we can be committed, you can will and bend the trajectory as people determine for better health and well-being. And because of philanthropy, we can capture so many different facets to what this initiative can hold.
Now, philanthropy provides the support system. It's not that they are being moved into social housing for the first time and left to themselves. You are providing social support. And Dr. Buzari, I believe that you also visit Dunhouse on a regular basis.
Yeah, so I do provide a clinic in place, and I was just apologize a few minutes late for mic checking as I was on a call for a patient at Dunhouse, which is a huge privilege to be able to see people who are there given the amount of work. And I do think it's a really important piece that the philanthropy enabled so much, but every level of government, the federal, the provincial, and municipal government has invested in Dunhouse. And I think that is a real coup when we talk about the kind of policy choices that we need and the kind of partnerships across various levels of government with philanthropy, with the private sector to end the homelessness crisis. And I have to say, I am still hopeful that we are going to turn the tide on this. As you saw and see different jurisdictions, cities like this in Houston, countries like Finland that had far worse rates of homelessness, but were able to push and essentially eradicate homelessness. Why we can't do this in Toronto, I refuse to accept.
So we have a question for you, Dr. Heyman, from someone who provides support for those living with homelessness from inside the shelter system and is asking for advice on how to improve communication.
With the emergency department?
With the homeless patients. How do you communicate? How do you build that trust?
Yeah, so I think in our emergency department, the thing that we have uncovered time and time again is every single interaction matters. So I like to think, our providers are a pretty compassionate, patient-centered group of folks. But what is so critical is, I can be the most compassionate doctor in the world, but if someone has had a negative interaction from the second they got picked up by paramedics until the time they see me, the whole encounter can be over. And the person might have actually left before I even get a chance to see them. So ensuring that the paramedics, the registration clerks, the security officers, the nurses, the physicians, the social workers, all the members of the team are utilizing a trauma-informed approach and are really talking to the person in a way that is respectful, but also acknowledges that they probably don't want to be there. They're probably having a bad day. They might be scared or tired or hungry or concerned about what is going on. Can really fundamentally help. I will say, again, the peers are so transformative in this because the other thing that really makes it hard in the ER, and I'm sure also in many supportive housing situations, is waiting. Like when you're waiting and you don't know what's happening, it doesn't matter who you are, it's a deeply unpleasant experience, it's very stressful. And so having someone there who's your ally, who can help you navigate the system, who can provide updates, which the peers do, they accompany people outside for some fresh air, help them come back in. Those kinds of things make a tremendous difference, and we're certainly not perfect in the emergency department, but are really working to provide a more compassionate, human-centered approach. And I think the peers have also just really changed the way that we engage with people because, many of the folks on our team who are non-peer workers maybe have had different experiences, but the peers talk about it openly. It's part of their role. And so I think that also helps us to see the humanity in everyone and to treat everyone with a little bit more kindness when they walk through the doors.
We actually have a question from the audience asking if we have a social worker working full-time in the emergency room.
Yeah, we have 3 often. We have social workers at both sites, daytime and evening. And we also have social workers funded through the Myrna Daniels Seniors Emergency Medicine Program project. So we have a social worker who's really dedicated to supporting seniors specifically. And I'd be remiss not to mention that about 10% of people who are homeless in Toronto are also seniors. So oftentimes people have really complex needs in that group. And then we have social workers who work very closely with our peer and our provider teams and spend a lot of time on some of the more nuanced and complex components of case management, and really work with the peers to determine which task is best suited for a social worker and which task is better suited for a peer worker. When we started the peer intervention, social workers were spending hours of their day making phone calls for shelter beds and for detox beds. And one of the things we heard from them loud and clear was it was not actually a good match to their skills and the additional needs. So now they're able to actually spend more time focused on some of those other tasks.
We're starting to run out of time, but I'll ask one more question from the audience. How does ER staff help patients who are unsheltered or marginalized in some way with chronic health conditions? Dr. Buzari, do you want to take that question?
Yeah, I mean, this is, I think, really the promise of the social medicine program, working with the emergency department so closely. So I think there's, I think for a long time, what we described as these sort of doom loops that happen, that people are in, that they're trapped in, that they're coming into the emergency department, they have chronic issues that cannot be dealt with. The amazing staff in the emergency department does everything they can in that sort of period. It's a revolving door, and individuals come back in. There's moral distress for amazing leaders and clinicians like Kate and the whole team about the realities that they can't prescribe things beyond or be able to reach the continuum of the sort of supports people need to prevent them from coming into the emergency department, which sees really sick people, people who are having real physical and mental health challenges that have been compounding. And so really the plan and the way that we've been able to see a shift in the way that we can care for people who have chronic issues that cannot be addressed fully or comprehensively in the sort of acute visit in the emergency department is part of the social medicine care model, that people get connected to a social medicine navigator that is not only able to advocate for them with the peer worker when they're in the emergency department, but as the follow-up outside. The other part of this has been the Phone Connect program that, again, was a real innovation at UHN. To credit many people to ensure that people were able to access cell phones in the emergency department if they didn't have them, to take with them so you could reach them beyond their visit. And then really also access to primary care once they're out of place that really has specialty in managing chronic disease. And we really believe that nurse practitioners and family doctors are part of the primary care solution piece. So we've hired nurse practitioners as part of the social medicine program, working alongside community health workers and social medicine navigators to address chronic disease issues so that hopefully they don't have to come back to see credible clinicians like Kate and their team, but that also that they know that that support is there if they need it.
What I love about the Gattuso Center for Social Medicine is it is a great example of extraordinary innovations that are actually changing the quality of care that's offered in our community that could never have happened without the support of our generous community. But that also has partnerships with the community groups, with the provincial government, with the federal government, with the city. It can be scaled across the country with very little money because of the data that's been gathered and the economic impact reports that have been published. So I do want to take the opportunity to thank both of you because you've been important leaders in social medicine across the country. And I do hope that the audience listening today is feeling as inspired as I am about the work that can be done when we bring brilliant people together who are passionate and dedicated to the cause. Before we close up, Dr. Heyman, Dr. Buzari, anything you would like to add or that you would like our audience to be aware of?
I would share tremendous gratitude to the foundation, who have been a phenomenal partner in this work, and to Andrew and the entire social medicine team. I mean, the growth that the program has had in the last 5 years and the strength of community partnership particularly with the neighborhood group, with Parkdale Queen West, with Inner City Health Associates, and to have all of that supported by the foundation it's been so fundamental to the work that we do in the emergency department. So we have tremendous, tremendous gratitude, and we are really, really excited for the future. There are big things ahead and big challenges ahead, but the model of collaboration and partnership that we've built, I think it's really so much is possible, and so I'm really, really excited about that.
Well, I want to redouble my gratitude for Kate, who's been such an amazing leader and partner in this work. And obviously for the foundation, Julie, I think your real support of social medicine and real personal commitment to seeing this grow over the last year especially has been transformative. And I do think in terms of the general view to put out, I think we can all feel that there's a lot of threat, there's a lot of uncertainty, there's a lot of fear outside the walls of the hospital, inside the hospital, in terms of the pressures that everyone right now is working through in terms of hospital bed occupancy. And I think the message for me is that where we've been able to show solutions that can work, we have to double down on them. And really, I think we've been able to have, and I would say personally, this privilege to not lose hope. And I think the power of philanthropy to inspire, push, channel this hope for sustainable solutions that will be in place far longer, all of us, far after, and knowing that these are daunting challenges as Kate laid out, I'm more hopeful and more determined than I think I've ever been, because we've been able to see impact. And once you can see that, you can't sit back and sort of say, well, we're going to have to, leave it to other governments or funders to make choices. There are ways that we can will different outcomes, and I'm so grateful to be able to do this work with the philanthropy, with various partners and family foundations, and with our community partners in a way that just hasn't been done before at the hospital level. So it's the honor of my career to do this work, and really looking forward to what's ahead, no matter what comes our way.
Dr. Heyman, Dr. Buzari, thank you so much for joining us. And thank you to our audience for joining us today. As Dr. Buzari mentioned, what is wonderful, and we had the question from the audience that we didn't get to, of whether or not the levels of government were supportive. I think what you heard today is, thanks to philanthropy, we were able to launch a number of different initiatives that have had massive impact on the healthcare of our own community, but also that can be scaled across the country. And the peer workers were a wonderful example. They were launched, the program was launched, thanks to the generous donation of the Gattuso Foundation. But the provincial government then contributed and is now funding a number of the peer workers, an example of what we can do across the country. We have received hundreds of small donations. Every dollar counts. But I do want to take the opportunity to thank the Gattuso Foundation, to thank the Sprott Foundation, to thank Ed and Tiffany Kress and Richard Rooney, who were founders and really supporters in launching this wonderful center and the initiatives that you heard about today. But that's not enough. We've proven that we can do it together. We've proven that we have incredible leadership, but we need your help to be able to bring it to the next level and make sure that this is available across the country. Thank you so much for joining us. We'll see you again in April when we have our next behind the scenes conversation. Have a wonderful evening.